Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Welcome to all colleagues and professors to the 13th week of Anesthesia and Critical Care refresher course under Saving Lives Academy. It's my honor and pleasure tonight to introduce one of the pioneers in nutrition, Professor Sohair Soliman. Professor Sohair is an anesthesia and critical care professor and the former head of anesthesia and surgical intensive care in Tanta University Hospital. Her area of interest is nutrition. Professor Sohair is an ESPN teacher and she earned a postgraduate diploma as well in the medical education. I strongly recommend to watch her previous talk under Saving Lives Academy in this course titled Nutrition in ICU, as this lecture is actually the foundation of nutrition management in critically ill patients. And tonight is her second presentation. So Prof Sohair, you can start sharing your presentation and please go ahead. You are muted still, Prof Sohair. You can unmute yourself, please. Yes, perfect. Thanks very much.
Thank you, Dr. Walid. Good evening, my colleague. It's my pleasure to be with you today. I'll speak about a very important, challenging topic, nutrition in intestinal failure. All of us know common organ failure like respiratory failure, liver failure, renal failure, and heart failure. Intestinal failure is a rare organ failure, but nowadays, due to advancement of surgery and surgical ICU, become more popular, increase number of intestinal patients referred with intestinal failure. Its management need challenge. Management of intestinal failure is management. You can follow me and join me on chat. What is intestinal failure? What's intestinal failure, please? 1 minute.
I have one answer here in the question and answer, loss of motility by Zahid Mahdi.
Only one answer?
Okay. Now more answers are coming on the chat. Fail after excision of intestine or stomach.
Yes. Intestinal failure is inability of gut to absorb necessary water, macronutrient as carbohydrate, protein, and fat, micronutrient and electrolyte, sufficient to sustain life and requiring intravenous supplementation or replacement, home parenteral nutrition to maintain health or growth. The pathophysiological classification of intestinal failure, short bowel is the main common cause of intestinal failure. Short bowel means resection, surgical resection of part of the bowel, either due to mesenteric vascular occlusion, volvulus, abdominal trauma, massive abdominal trauma, or also other causes of intestinal failure like intestinal fistula, intestinal dysmotility, mechanical obstruction, which cause decrease of absorption. Extensive small bowel mucosal disease affect on absorption like Crohn's disease or radiation enteritis. We anticipate short bowel. When we anticipate short bowel, when small bowel ostomy and less than 200 centimeter small bowel, or less than 100 centimeter with colon, or stoma or fistula output more than 1.5 liter per day. 50 to 80 centimeter small bowel with half of colon. This is the minimal length allowing patient to be independent on home parenteral nutrition. The minimal length, 50 to 80 centimeter with half of the colon. All these conditions have high risk of malnutrition, but not all short bowel patients need home parenteral nutrition, but need nutritional support, nutritional counseling, and monitoring. This is a painful case history, real case, male patient, 60 years old, presented with mesenteric vascular occlusion, jejunum only 10 centimeter remnant with jejunocolic, all the jejunum and ileum removed except 10 centimeter. The patient on peripheral parenteral nutrition in form of saline and glucose, that is all, for 30 days. Then patient is severely malnourished because he is intestinal failure for 1 month, nothing per mouth. And management in this patient is challenging. What we do for this patient? What we will do for this patient? First, assessment. Body weight 71 kilo, previous 91. This patient lost about 20 kilo in 1 month. BMI 27, phase angle 3.9 on BIA. This means decreased function of the cell, severely malnourished. Albumin 2.8. Is this patient malnourished? Please on chat, write on chat. Is this patient malnourished and why? No answer? Is this patient malnourished? From Ahmed El Gindi, yes. Why malnourished? Yes, this patient is malnourished. We do nutritional assessment for our patient by nurse nutritional risk screen. This parameter of nutritional risk screen, BMI, if less than 20.5, take yes or no. Weight loss in last 3 months, take yes or no. Decreased dietary intake in last week, either yes or no. Is patient severely ill? Our patient, what about our patient? BMI 27, take yes or no? No. But weight loss in 1 month, about 20 kilos. The patient lost more than 10% of his weight in 1 month. Decreased dietary intake, yes, nothing by mouth for 1 month. And our patient is severely ill. Yes, our patient is severely malnourished. Okay? What is the problem in short bowel? The problem in short bowel, nutritional problem, macronutrient and energy deficiency, water, sodium loss, magnesium, potassium loss, vitamin and trace element loss or deficiency. Other problem like bile salt diarrhea, gallstone, oxalate absorption from colon and renal stone, D-lactic acidosis. Another question, how many liters of fluid is secreted by the gut? How many? Please answer. 7 liters, 12, less than 1.
I have 3.5 and 2 to 2.5 by Amr and Zaid in the question and answer section.
12 liter, 7, 6, 12 liter. Okay. Intestine secrete about from saliva about 1.5 liters, from gastric secretion about 2.5 liters, from pancreas about 1.5 liters, from intestine 1 liter, total 6 liters and half, besides added 2.5 liters from oral intake. On the other side, absorb from intestine 7 liters, from colon 1 liter and 900. Total about 8 liter and 900 then in the end, secretion equal absorption. This is what happened in normal person, normal individual. Secretion equal absorption. A net result in healthy person is absorber. What's meant by absorber? When drink more, absorb more, because secretion equal absorption. During dehydration, patient feel thirst. More drinking, increase fluid retention and restoration, resolution of the condition. This is what happened in a normal individual. What happened in short bowel? In short bowel, إيه اللي بيحصل? What happened? Secrete, saliva secrete 1.5 liters, gastric 2.5 liters, pancreas 1.5 liters, and loss 1 liter from intestine. The total 5.5 liters, and absorb only from the colon 1 liter and 900, plus absorption from intestine. Then the total is 1 liter and 900. So the oral intake, the end result, secretion is more than absorption, and diarrhea, loss of fluid. Short bowel is secretor. This means, what's meant by secretor? Drink more, absorb less. During dehydration, patients feel thirst, drinking, increase in fluid loss, and deterioration. Patient take thirst, they clear fluid and loss. The result of that, patient stop to drink, afraid of diarrhea, but the condition is more deterioration. Even the patient come with early sign of renal shutdown due to dehydration. This is a problem. Really, it's a problem. Patient stop to drink, or when they drink, more diarrhea. What we will do for this patient? Secretory more than absorption. Before dealing with patient, before management, we must know site of absorption of macronutrient and micronutrient. As regards carbohydrate, protein, and lipid, macronutrient mainly absorbed from duodenum, upper part of the jejunum, and upper part of ileum. The maximum absorption from the duodenum and first 150 proximal part of the jejunum. Calcium, iron, and folate absorbed mainly from the duodenum, also from the jejunum and ileum. As regard the bile acid absorbed from distal ileum, also vitamin B12 absorbed from distal ileum. Also, we need to know before management of our patient to know a type of short bowel, remaining part of the intestine, and get full surgical history. Either patient, the colon is removed or preserved, ileostomy, jejunostomy, how many parts or remaining parts. or colon is preserved, ileocolic, jejunocolic, our patient is jejunocolic. Also, you must know ileocecal valve present or not. It's very important to know this condition before management of speech. Why? Why it's important? Because I know many things from the remaining part. Preservation of the colon is important for fluid balance and nutritional gain from fermentation of unabsorbed carbohydrate and fiber, which give short chain fatty acid, which give about 5% of energy. Also, preservation of ileocecal valve prevents small bowel bacterial overgrowth and has a physiological slow of intestinal transit, which enhance absorption. Preservation of ileum, ileum is highly adapted to absorption of macronutrient in case of shortening of the jejunum, and also compensate loss of colon and increase the fluid absorption. This is very important to know remaining and functional part of the intestine. Now we go to the management. We follow in management ESPIN guideline on chronic intestinal adults. Adaptation of the intestine occur within 6 months up to 2 years. Adaptation is through increased surface area and hyperplasia. This adaptation need to enteral feeding, trophic feeding for enterocyte to enhance adaptation. In our management include fluid, include nutrition, include drugs. As regard the oral diet, it aim maximize macronutrient and electrolyte, minimize the volume. As regard the fluid, there is a common problem, as we said, when patient first take clear fluid, more diarrhea, stop drink. It's how to solve this problem by giving to the patient salt-rich fluid. Some patients cannot tolerate this salt-rich fluid, but we weigh benefit, risk-benefit for the patient. As regard the treatment in high output state, drink little hypotonic fluid, only 500 ml per day clear water or sodium-free water, 500 ml per day only. The rest of fluid taken as drink a glucose saline solution, about 1 liter or more. Patient also take 500 ml per day as soap, salty soap, any type of soap. Drug therapy, antimotility, lopramide, Imodium taken before meal, start from 4 mg to 16 mg per day up to 32 to decrease motility and enhance absorption. And secretory as omeprazole taken 40 mg per day to decrease gastric acidity, enhance enhance pancreatic enzyme activity, and enhance digestion and absorption. These drugs taken for 6 months. Also magnesium supplement and nutrition. This is the oral rehydration solution. How to prepare this solution? 1 liter of clear water, added to it 2.6 gram of salt, 2.9 gram of dry sodium citrate dehydrate, 1.5 gram potassium chloride, 13.5 gram anhydrous glucose added to this 1 liter, and patient drink all over the day. The oral diet in case of jejunostomy patient, as regard energy, high energy, 30 to 60 kilocalories per kg per day, protein high, protein from 80 to 100 gram protein per day, fat high, fiber low. As regard jejunocolic, colic is preserved, high energy, 30 to 60 kilocalorie, protein high, 80 to 100 protein per day, fat low and moderate according to degree of steatorrhea, fiber and carbohydrate high and moderate to get benefit from fermented bacterial fermentation of fiber and carbohydrate to get short chain fatty acid and energy. Oxalate is low. As regard the protein, how much protein according to the condition of patient, either 1 gram per kg, 1.2, 1.5. As regard the underlying disease, the specific need of patient, acute illness, protein malnutrition. During intestinal rehabilitation strategy, medical, regular whole food diet, regular, all diet take, but salty diet, and are encouraged to compensate for malabsorption by hyperphagia. Patient all the day, patient take food as he can, and I can introduce at night nasogastric tube and put enteral nutrition, because I need more and more nutrition, because patient, if need 1,000 calorie, I put 2,000 to absorb 1,000. Patient with preserved colon consume a diet high in complex carbohydrate and low in fat, high content of medium chain triglyceride. Addition of oral isotonic nutritional supplement may be benefit. Glucagon-like peptide 2, it's a natural peptide production from intestinal cell in ileum and colon, release stimulated by luminal nutrition. Then luminal nutrition stimulate the release of glucagon-like peptide. And receptors mainly in jejunum and proximal ileum, action strong intestinal trophic properties, increased mucosal proliferation, increased nutritional absorption, nutrient absorption, increased intestinal perfusion, increased cytoprotection and bone density. There is a promising drug nowadays, tetraglutide, which is analog of glucagon-like peptide, which has a benefit and enhance intestinal rehabilitation, intestinal adaptation through increased intestinal perfusion with mucus proliferation, but is very expensive. I think it needs $300,000 per year, but it's promising to decrease the dependence of the patient on home parenteral nutrition and increase intestine adaptation. Home parenteral nutrition. Is our patient need home parenteral nutrition?
Yes.
Please share me. Is our patient need home parenteral nutrition? No answer? And what?
Yes, in question and answer section by Zahid.
Yes, need. Why need home parenteral nutrition? Our patient, why he need home parenteral nutrition? I'll answer. Because our patient, the remaining part only 10 centimeter jejunum, and the least is 50 to 80 with half of the colon, which can tolerate nutrition or adaptation and maybe not need home parenteral nutrition. But our patient need home parenteral nutrition. What's the problem with home parenteral nutrition? Home parenteral nutrition needs teaching, education of the patient to care about central line, to care about solution or nutrition solution. Any complication appear, then patient need very tight education and teaching. We give home parenteral nutrition to maintain fluid, maintain energy for patient, and also need enteral nutrition to maintain trophic feeding of enterocyte and enhance the adaptation of the intestine. Then we give home parenteral nutrition and enteral parenteral nutrition, hyperphagia for the patient, more enteral. Monitoring, the patient need monitoring. Biochemistry need CBC, hemoglobin, iron, ferritin. Commonly, patients with intestinal failure have anemia. Also need to sodium, potassium, magnesium, phosphorus, calcium, and correct any deficit in our patient. Anthropometry should be measured at all visits. Trace element and vitamins are recommended at interval of 6 months because patient liable to has osteoporosis, vitamin D deficiency, folate, B12. These vitamins must be added to the patient in management. Bone mineral density assessment by DEXA to scanning is recommended at yearly interval to detect any deficiency on vitamin D and calcium associate patient to develop osteoporosis. Parenteral nutrition delivery for patient either single component, amino acid glucose lipid, or 2-in-1 admixture, or 3-in-1. Or maybe aseptic compounding if present in hospital, aseptic compounding with filling machine and need aseptic laminar flow to prepare a solution for parenteral nutrition. Also, parenteral nutrition needs central venous access. Central venous access, peripheral inserted central catheter or central venous catheter or Heckman tunneled catheter or implantable port. Heckman tunneled catheter need when patient need catheterization more than 3 months. Then Heckman catheter commonly used for home parenteral nutrition. There is a different type with more lumen covered by transparent dressing. Blood draw should be avoided to avoid an infection, but take care lumen for nutrition or parenteral nutrition, not used for any purpose, not for drugs, not for aspiration to analysis, anything. Port for nutrition is only for nutrition. A risk associated with parenteral nutrition, either infection, catheter-related infection, microbial contamination, metabolic as intolerance, hyperglycemia, keep level of glucose between 150 to 180, refeeding syndrome, bone loss. Also with long-term parenteral nutrition, patient may develop cholestasis and hepatic failure, mechanical complication like catheter occlusion. Other approach for intestinal failure, prompting surgical approach. A surgical approach to restore restorative surgery, repair the fistula, restore intestinal continuity, or operation for intestinal lengthening, as Bianchi technique, steep technique, or intestinal transplantation. This intestinal lengthening aim, Bianchi technique or steep aim to increase surface area of absorption, mixerial transverse enteroplasty. Really, there is a challenge in management of short bowel or intestinal failure Because according to ESPEN guideline, we need multidisciplinary team. We need multidisciplinary approach, team surgery, GIT, intensivist, nutritionist, clinical pharmacy, nursing, and also very important to need to non-profit organization for caregiver, because parenteral nutrition is very costly. Nobody can tolerate the cost and not covered by insurance. In my case, I deal as a single one-man show, single approach, home parenteral nutrition, not governmentally approach. It's very, very difficult and challenging for me. There is a lot of organization. There is a lot of organization for caregiver and patient on home parenteral nutrition and for clinician. This is very important, this non-profit organization. We hope this organization to more development in all countries to cover home parenteral nutrition. Also, we hope development of surgical maneuver for intestinal transplantation. Still, the puzzle not complete. We need more management. We need nutritionist, NGOs, surgeon, and patient for education. The way of 1,000 meals start with a step. I hope we develop more and more in management of intestinal failure. And thank you.
Thanks very much for this comprehensive lecture, Prof Sohair. We are waiting for the questions from the attendees here. Any questions? You can put your questions, please, in Q&A section or even the chat, so we can deliver them to Prof Sohair. So to prevent malabsorption, need for nutrition, what about, okay, that's an old question, I think. Okay.
What's the question?
It's an old one during the talk. I think he was trying to answer your question. So there is a question here for me, actually. What about CME certificate for all the sessions? For who are arrived lately during the course, we will supply all the CME certificates after the end of the course. If you attended more than 70% of the course, you will get the 45 CME points. The course is accredited from Alexandria University Hospital. So it takes a huge effort to calculate the CME hours for everyone. So we'll do this job as a whole after the end of the 6th month because it takes a lot of effort from us. And as you know, there is no fund for this course, so I'm doing almost all the job on my own. So please accept my apology. All the certificates will be available by the end of the course. So the first question here from Zahid Mahdi: when I should start to consider intestinal failure as a problem for the patient? When should I start considering intestinal failure as a problem for the patient?
Intestinal failure is a problem for patient. Because
so
no
when
absorption,
he's asking
according to the remaining part of the intestine, which affect